Hey everyone. All right, so today we're going to be talking vital signs. So vital signs, we also call them cardinal signs, uh, are letting us know how the body is doing. Okay, this is a big thing that the medical assistant is going to be doing on a day-to-day basis. You really need to know how to do these things. So vital signs can include your temperature, pulse, respiratory rate, and blood pressure. We also might even include the pulse oximeter, which is that little clippy thing that will typically go on a finger. And what that is telling us, it's the oxygen carrying capacity of your capillary blood. So that's giving us an idea of how well somebody is oxygenating. We also might add anthropometric measurements. Those are including height and weight. Now, not everybody are we going to be taking the height of all the time. But we really will be monitoring a lot of weight. Okay, so you're going to have these are baseline measurements. You're going to start with the very first appointment and then kind of monitor people as they go through. Just so we know how somebody is doing, if they're getting better or if they're getting worse. All right, so weight. Weight is typically taken every visit, especially for your prenatal infants and children. We're trying to see how they are, and maybe even for some older adults. We have to look at some of these older individuals. They could have a diagnosis of, let's say, congestive heart failure, and they might have to be monitored either daily or weekly for their weight because they can develop what we call pulmonary edema, fluid going into their lungs. And they can add 1 or 2 pounds of weight within a day. That's just from fluid retention. So it's very important that we watch them and monitor them. There's different types of scales. You can see there's the balance beam, which is the standing scale. You have digital, it might be dial. In your doctor's office, it's really going to vary depending on your physician's preference. They can either weigh it in pounds or kilograms. A lot of medications are going to be weight-based, and when that is considered, it's going to have to be done in kilograms. Height. Now, height is not always measured for most individuals, but for those who are growing and potentially those who are shrinking, we're going to have to monitor their height. So usually infants and children, as they're growing, we're going to be measuring them every appointment. And maybe somebody who is in our geriatric population, if there's that potential of shrinking, we're going to measure them. So if it's a wall-mounted height beam, or if it could be on a standing scale, you're going to raise that bar up and it's going to rest parallel on top of their head. And that's how you're going to measure it. Height can be measured in inches or centimeters. Excuse me. Again, this depends on the physician's preference. All right, so now let's look at our cardinal signs or vital signs. So first we're going to talk about temperature. All right, so temperature is just letting us know what our body is doing. It's going to give us an idea if we are fighting infections or not. So it's produced through metabolism and muscle movement. We can also lose it through respiration and elimination. So in normal temperature, what we kind of think of as the normal temperature can range between 97.6 and 99.6 degrees Fahrenheit, which gives us an average. What we consider a norm is 98.6 degrees Fahrenheit, and that would also be 37 degrees Celsius. So some basic terminology here. Remember, when we see A in front of a word, it means without. So febrile, we think of as fever. So if somebody's febrile, they have an above normal temperature. Afebrile is without fever. I'm keeping it very simple. Okay. So here you can see some different factors that influence heat loss and heat production. All right, evaporation from the skin, the lungs, that can increase the heat loss. Exercising, shivering, tensing of muscles, that will increase the heat production. We're looking at temperature. There's different ways that we can measure it. Oral is the most common, and so that's where we think of the average temperature is taken orally, so that's 98.6. Your oral, your tympanic, and your temporal are all going to be normal temperature for them will be 98.6. They all are relative to one another. So tympanic is in your ear, and the temporal is a scan across the forehead. The rectal temperature, we look at rectal as being bright, right? This is the most accurate measurement of temperatures. So rectal temperatures are usually 1 degree higher than oral. Okay? And then when we look at axillary, axillary is underneath the armpit, and that's measured typically 1 degree lower than oral. So when we're documenting, we have to be very careful to document where we are taking the temperature and try to be consistent. If we change it up, it's even more important to document where we're taking it, because we might not understand if somebody has a fever, if one time we took it rectally and then another time we did it axillary, because that could be a whole 2 degrees difference. Because remember, axillary is 1 degree less than oral, and think of oral as being our baseline, then rectal is 1 degree higher. Stages of fever. Okay, so an elevated temperature, what we think of as fever, usually comes from a disease process. Maybe there's a bacterial or viral infection, but there are other factors that can affect temperature. So age, usually children have higher temperatures, where our older adults have lower temperatures. Our gender, women typically have a higher temperature, and it can fluctuate with ovulation. The exercise, time of day, usually time of day in the morning, it's a little bit lower. If we have emotional stress, it might appear to be higher. With depression, it can be lower. So there are different things that can affect our temperature. So we have different terminology. So we learned about febrile, which means an above normal temperature, and afebrile, without temperature, so without a fever. Now we have a better classification of the different types. So pyrexia is a temperature of 101 degrees oral or 102 degrees rectal. So we think of anything that is, when we're getting to 102 degrees core body temp, they are pyrexic. Hyperpyrexia is when you have an oral temp of 105 or a rectal to 106. That is hyperpyrexia. So it's a much higher fever, and we have to be concerned. The onset, it could come on rapid or it could be gradual. And then there's just some different terms for it. Sustained fever, that's a fever that is constant. It's not fluctuating at all. Remittent fever means one that is fluctuating. Intermittent, it kind of comes and goes, so it's happening at intervals. And then relapsing, that's where you have a period of time, so you had a fever, then you had a period of time where you were within normal limits, and then it returns. Different types of thermometers. There's glass thermometers, which we really don't use that often any longer. With the glass thermometer, they used to be mercury, but now it's non-mercury. So they're wider, and they're really inconvenient because you have to hold them in place 3 to 5 minutes, depending on where you're taking the temp. Then there's tympanic. Tympanic is what goes in the ear. We have to be mindful when we have smaller children. You have to pull the ear down and back to line up the ear canal. And when you have adults, you should be pulling on the ear up and back. If you just simply put the tympanic thermometer in someone's ear and shoot it, you're not going to get an accurate temperature. Then we have electronic thermometers. There'd be all different types of digital thermometers. We have the temporal artery thermometers that scan the forehead to the temporal artery. And we have disposable thermometers, and that could be just little pieces of paper or plastic that's going to read temperatures. Now we're going to talk about the pulse. So every time your heart beats, it's pumping blood around your body. And every time that when we are feeling and we feel that blood hitting the arterial wall, that is 1 heartbeat. So we are counting how many times your heart beats in 1 minute to give us the pulse rate. We have the apical pulse. Now the apical pulse is probably the most accurate method to determining a heart rate. This one you're going to actually listen with a stethoscope, and you're going to go over the apex of the heart. Now remember, your heart sits in the center of your chest with the apex, or the tip of the point, over towards your left side. So to locate your apical pulse, you would come down your clavicle, so your mid-clavicular, and you come down to about the 5th intercostal space. And that's where you're going to place your stethoscope, and you're going to listen and count for 1 full minute. Now sometimes with children, if we want the most accurate pulse rate, we will do an apical pulse. In other areas, if we have to do cardiac drugs, we're going to do an apical pulse, because again, this is the most accurate. You're listening and counting for 1 full minute. So we're going to look at some pulse characteristics. So we're going to look at the rate. The rate is the number of heartbeats in 1 minute. Okay, so this is when you are feeling the pulse and you're feeling it against your fingers, you are calculating the rate. Right? The rhythm is the interval between each beat. Okay, and we want to see, is it regular, irregular? Does it march out in time, or is it kind of skip, jump? All right, so we're seeing, is it spaced out evenly, or is it kind of all over the place? So we want to know, is it regular, irregular? And then volume. Volume is the strength or force of the heartbeat, and it can be described as soft, bounding, weak, thready, strong, or full. So this will kind of let us know how much blood volume they have, depending on how we feel that pulse against our fingers. Right, there's different factors that can affect your pulse rates. So time of day, okay, it's usually lower in the morning than later in the day. Our gender, our body type and size. Typically, now remember, it's not always necessarily the case, but typically tall, thin people usually have a lower pulse rate than do shorter, stockier people. Okay, exercise. If you exercise, what you're doing can increase your heart rate, but also if you exercise a lot and you're used to having increased heart rates, your resting heart rate can be much lower than normal people. For example, if you have somebody who is a runner and they run many miles every day, their resting heart rate could be in the 40s. Whereas for other individuals, if their heart rate was in the 40s, they might feel very weak. Their eyes might be a little bit droopy, rolling back in their head. They can have a lot of issues. Stress and emotions can affect your pulse. Fever, we're going to have an increase typically in our heart rate when we have a fever. Medications, they can either raise it or lower our heart rate. And blood volume. So if somebody's bleeding out or they're dehydrated, initially we're going to see an increase in somebody's heart rate because you have to pump around whatever oxygenated blood that you have. So now we're going to talk respirations. The act of inhalation, exhalation is one respiration. So again, we're going to see how many times somebody is breathing in and out in 1 minute. That will give us our respiratory rate. Different textbooks can give you different considerations, what they think is normal. Some will say 14 to 20, some will say 12 to 20, and there might even be some that say 10 to 20 as far as a respiratory rate. We really try to look at what is normal for that individual. So what we're doing is we're counting how many times somebody's breathing in and out. You can count for 15 seconds, multiply by 4, count for 30 seconds, multiply by 2, however you want to do it, but it's how many times somebody's breathing within that minute. One of the big things about respirations is we don't want to let somebody know that we are counting the respirations. That is one vital sign that we have full control over. I can hold my breath and actually stop my respiratory rate. Where we can't do that with our pulse and our blood pressure. We can try to modify them a little bit by our activities, but respirations we can actually control. So again, some of the characteristics, the rate, we're going to see if they're within normal, right? Sounds, that's a big thing. We're going to listen. If we hear respirations, and we can hear a lot of things, we can hear wheezing, we can hear stridor. Normal respiration should be quiet and effortless. We really shouldn't be hearing people breathing, right, or struggling. They shouldn't be working hard to breathe. So you see that children or infants, much higher, 20 or more respirations per minute, a child 18 to 20. So it just varies by your age group. Here are some different abnormal respirations. Tachypnea, that's that faster rate. Remember tachy, meaning fast. Bradypnea, brady again meaning slow. Dyspnea, difficulty, so DYS means difficulty, so difficulty breathing. Apnea, we look at A means without, so apnea is no respirations. Hyperpnea, so that deep gasping for breath. Hypopnea, that's shallow. Orthopnea, this is where you have trouble breathing lying down. You might see this again for congestive heart failure patients with a lot of pulmonary edema. So they fill up as soon as they lay down, they can't breathe. Hyperventilation, that's when they're breathing just way too fast and they're blowing off too much CO2, carbon dioxide, and so it will actually kick out their need to want to breathe. Now we're going to talk about blood pressure, right? So when we were talking about pulse, we were feeling the artery, and as the heart would beat, we're feeling the blood hitting the arterial wall. Now what we're doing in blood pressure, we're actually measuring the pressure of the blood as the heart is beating, as it's hitting those arterial walls. So when we look at the cardiac cycle, that's the period from the beginning of one heartbeat to the beginning of the next. And in that we have systole and diastole. Systole is the contraction phase of the cardiac cycle, and diastole is the relaxation phase of the cardiac cycle. So when we're looking at blood pressure, our systolic pressure, which is going to be the top number, that is how much effort it takes for the heart to contract and pump blood all the way around the body. Our diastolic is during the relaxation phase. So that's our last sound that we hear, the lower number, and that's how much effort it takes for the heart to relax and fill. So you can see here normal. So normal is less than 120/80. Elevated, which we consider pre-hypertension. So you're at risk for high blood pressure. The systolic 120 to 190. The diastolic here, we're kind of like, we're just going to kind of wait and see what happens. And then we go to stage 1 hypertension. You're in that 130 to 139, and now you're starting to move that diastolic a little bit in the 80s, upper 80s. Then high blood pressure, our stage 2, our hypertension, 140 or higher, and then our diastolic 90 or higher. When it's a hypertensive crisis, we're really concerned, and again, you're going to have to take this individually too. Sometimes patients who have lower blood pressures, normally 90, for them they could almost be in a hypertensive crisis if they are at 160, 170, because they're just much further out than where they normally are. But we want to be really concerned with a systolic over 180 and a diastolic over 130. We have to be watchful. There's a potential for stroke. So another type of blood pressure that I'd like to mention is orthostatic hypotension. We also call it postural hypotension. This is where we have a sudden drop in blood pressure when we do position changes. So maybe you're laying down and you stand up, and they have, and this is where people might black out, pass out, but we have a big drop in blood pressure. A lot of times with these type of patients, you might do what we call orthostatics. Some people call them tilts. So you'll take a blood pressure and pulse while they're laying. Then you'll sit them up, and within 30 seconds, you're going to take a blood pressure and pulse. And then standing, again, we're going to take a blood pressure and pulse. We want to see if there's a big difference with position changes. So here we're going to talk about corticough sounds. So corticough sounds are, when you're going through, there's 5 phases of blood pressure. All right, so when we're listening, we're going to hear some different sounds of the blood pressure. So the first sound we hear is that faint tapping as the cuff is just starting to open up and release. And that first sound is our systolic blood pressure. That's our phase 1. So it starts off with tapping, then it goes into a swishing, and then it goes into more of a sharper, distinct, louder tap, and then it starts to fade away until we get to our last sound. So our phase 1 is our systolic, where it's first starting. 2, that soft swishing. 3, that's that loud, distinct tapping. 4, fading away. And 5 is our diastolic. Our pulse pressure. So to determine the pulse pressure, that's simply the difference between the systolic and diastolic readings. So basically all you're going to do is subtract. So you're going to take the top number, which is your systolic pressure, and you come up with your diastolic, the lower number, and you're going to subtract them. The average normal range for pulse pressure is 30 to 50 millimeters of mercury. Remember, when we are measuring any kind of blood pressure, it's always in millimeters of mercury. That's just what the gauge is. Okay. Excuse me. The pulse pressure should be no more than 1/3 of the systolic reading. We really want to be mindful of that. And then auscultatory gap. So the auscultatory gap is when there's a loss of any of the sounds for up to 30 millimeters of mercury, and it could be even more during the release of air from the blood pressure cuff. So after we hear that systolic and we're releasing it, and then the sound goes away, and you keep going down, and then boom, it all of a sudden comes back. This is an auscultatory gap. So it can cause errors in blood pressure readings. So you really have to kind of watch and listen. All right, there are some factors that can influence blood pressure. One of the biggest things is not using the appropriate size cuff. So if you were to look on the inside of your cuff, at the very end of your cuff, there's a white line. And typically going along the inside of the cuff, you're going to see another white line. Your white line for the Velcro should always fall in between that other white line. That's showing you that it's the appropriate size cuff. Right? Using the wrong size cuff can throw the blood pressure off for up to about 30 millimeters of mercury. And so somebody could be medicated and treated improperly because of the wrong size cuff. So you want to make sure you have the right size cuff. Too small of a cuff on somebody's arm is going to make their pressure seem higher, and too large of a cuff on somebody's arm is going to make them seem lower, their pressure seem lower. Other factors, the diet, whether we exercise or not, if you use alcohol, tobacco use, your past medical history, family history, those are all things that can affect your blood pressure. Atherosclerosis and arteriosclerosis, that is where we have the decreased elasticity of our blood vessels, and that can happen as we age. We have decreased elasticity. So if your vessels aren't expanding and contracting as well, you're going to see an increase in blood pressure. You can also have hardening if you're building up plaque and things like that. So you have hardening and of the narrowing of the blood vessels, and that can increase your blood pressure. So there you see, so age, as the older we get, we'll have higher blood pressure. Exercise can affect it. If you're just being very active, you could have a higher blood pressure. Our body position. So typically when we're laying flat, supine on our back, it's going to be a little bit lower. And then of course medications. Medications can affect it one way or another. So we have to take all of these things into consideration when we're taking someone's vital signs. So that is it for vital signs.